Hi, and welcome to MedInsights Unleashed podcast. I'm John Collins, and I hope you enjoyed this new episode, and thank you for listening. Welcome to the MedInsights Unleashed studios, and welcome back Dr. Ari Rosenberg, Assistant Professor of Medicine at the University of Chicago Medical Center. Ari specializes in head and neck cancer, salivary gland tumors, and thyroid cancer. He has completed 3 episodes with MedInsights Unleashed. His first episode, Unveiling the Invisible Enemy, entails diagnosis and preventions we can take to reduce the risk of head and neck cancer. His second is on a deeper dive into recurrent head and neck cancer, locally advanced and metastatic disease, the treatments, and the role of immunotherapy. His last is talking about liquid biopsies in the neoadjuvant setting, how circulating HPV DNA measured through a simple blood test is emerging as a powerful tool to guide decisions, personalized treatments, and potentially reduce the need for aggressive surgery or radiation. Today's discussion is centered on the recent groundbreaking data that has been presented at ASCO regarding the neoadjuvant and adjuvant settings.
Thanks, John. Great to be back.
So can you fill the audience in on what you've been doing since you last did your episode and what research that's happening in Chicago Medical Center? And then we can get into an overview of ASCO.
Yeah, that sounds great. And we've continued to take care of many head and neck cancer patients. This continues to be a major problem within the population and a very difficult to treat disease, as we've talked about in some of the previous episodes. We have 2 distinct types of head and neck cancer that we treat. We have HPV-positive, HPV-associated head and neck cancer. This type is continuing to increase in incidence and is going to continue to increase in incidence for a couple more decades based on current predictions. And this disease actually has a pretty good prognosis, and in that way, much of the efforts have actually been on thinking about who can we de-escalate treatment for to maintain the excellent survival outcomes we see with HPV-positive oropharynx cancer, while at the same time reducing treatment-related toxicity. And our group and others have been working on efforts to try to sort that out. Ours has been with neoadjuvant immunotherapy. But the other type of head and neck cancer that we see is what we call HPV-unrelated head and neck cancer. HPV-negative head and neck cancer is the other name for it, which classically is associated with carcinogen exposure, heavy smokers, folks with history of alcohol use as well. Although we do see HPV-unrelated head and neck cancer in non-smokers also. And this type of head and neck cancer has a much worse prognosis. In the local regionally advanced setting, we only managed to cure about half of these patients, so we have to do much better. And this is where there's actually been quite a bit of innovation recently within the head and neck cancer space. You alluded to it in your previous comments, that we now have an established role for perioperative immunotherapy for PD-L1 expressors with surgically treated head and neck cancer, and we can certainly talk about that data. That's been a practice-changing data set that's come out that has changed the way that we approach these patients as standard of care based on a number of studies, including some of our early work as well of neoadjuvant immunotherapy. And we've also been seeing a wave of exciting novel therapies in head and neck cancer, particularly for the HPV-unrelated group. And that's particularly exciting, I think, because even when head and neck cancer recurs, survival remains worse for HPV-unrelated as compared with HPV-associated head and neck cancers. We actually presented at ASCO this year some real-world data after patients progress on platinum-based chemotherapy and immunotherapy, which are our most active therapies that we have for these diseases. And the survival in real world data set, even in that setting, it remains quite poor, with only about 6 months survival rate for HPV negative, about 9-month median survival for HPV positive, but both, clearly there's a need for improvement in both these diseases. But there's been a number of novel therapies that have been of excitement. One category of novel therapies has been some of the bispecific antibodies. So these are drugs that target two molecules simultaneously. The three that are currently in phase 3 trials target EGFR, epidermal growth factor receptor, which has been a long-standing target in head and neck cancer. It's overexpressed in the vast majority, over 90%. And so all three of these new bispecifics target EGFR and something else. One of these, and we can talk about it, had very exciting data at ASCO, is a drug that's called amivantamab, which targets EGFR and a protein called MET. So we saw data for that drug at ASCO this year. There's also a bispecific antibody called petosemtamab, which targets EGFR and a stem cell marker called LGR5 that has exciting data and is currently in phase 3 trials in head and neck cancer. And then the third drug is a drug that's called ficerafusp alpha, which targets EGFR and a target called TGF beta, which is an immunosuppressive marker within the tumor microenvironment. And that also had some promising data with pembrolizumab and is also is in phase 3. There's been a number of other categories that we can get into. Antibody-drug conjugates making a lot of waves. We presented some of our data looking at HPV therapeutic vaccination in the neoadjuvant setting for HPV-positive head and neck cancer. We don't want those patients to get left behind with all the innovation happening in the HPV-unrelated setting. And I think I'll stop there. There's lots of stuff happening, but that's a snapshot, I think, of where things are and where things are going, and certainly what we're excited about at our center with our large head and neck cancer program.
Yeah, that's amazing work, and congratulations on the research. I'd like to step back into that perioperative immunotherapy data, if you would expand on that area, because that's really earth-shattering and a major breakthrough. We talked about that in 2 of your previous podcasts. That data was fermenting, is a way of probably saying. Now it's actually out there and realistic, and it's and I'm sure a lot of patients would not know about that data. They've probably seen the headlines, but not involved in the in-depth discussion. So, Ari, if you could talk about that, would be great.
Yeah, absolutely. I'm happy to. The practice-changing trial was a trial that was called Keynote 689. And this was actually a trial that built a lot of promising early phase clinical trials that tested neoadjuvant, meaning given before surgery or definitive radiation-based treatment, giving immunotherapy, PD-1 inhibitor. We've known for some time that immune checkpoint inhibitors or immunotherapies, drugs that target PD-1, program death 1 in particular, have an established role in the recurrent metastatic head and neck cancer setting. Pembrolizumab and nivolumab after progression on platinum-based chemotherapy, and then in the frontline recurrent metastatic setting, pembrolizumab alone or in combination with chemotherapy has an established role, and that's been the standard now for quite some time. But it's actually been more of a challenge, I think, than many expected to bring immunotherapy into the local regionally advanced, the curative intent setting, which is very important, right? Most of our patients are diagnosed in the local regionally advanced setting where their disease is potentially curable. And as such, curing more patients is of the utmost importance. Some of the initial trials actually tried to combine immunotherapy, so immune checkpoint inhibitors that target these immune molecules, in combination with chemoradiation, definitive chemoradiation for high-risk local regionally advanced head and neck cancer. And actually, those studies were initially disappointing. The first study was called the Javelin study,
Right.
which randomized patients with high-risk local regionally advanced head and neck cancer to the standard, which is chemoradiation with cisplatin, versus the experimental arm, which added avelumab, which is a PD-L1 inhibitor. And I should point out that PD-L1 inhibitors have not worked very well as well in head and neck cancer as PD-1 inhibitors. But avelumab was the drug that was tested, given during chemoradiation and then after chemoradiation. And that was a negative study. The only group that trended towards benefit was the very high PD-L1 expressors. But overall, it was a negative study with the experimental arm actually trending worse in terms of outcomes compared with the control arm. Exactly what you don't want to see in a trial like that. The other trial was called Keynote 412. And this trial was a very similar design, but instead of avelumab, was testing a drug called pembrolizumab, PD-1 inhibitor, and that's an established immunotherapy in head and neck cancer, right? Has multiple FDA approvals in the recurrent metastatic setting. And the primary endpoint was not met for this study. So that also was a negative study. There is a recent update that adds a little bit of nuance to that negative study, which is that with longer follow-up, now with 5-year follow-up and enriching for PD-L1 high expressors, again, the caveat is that the trial was not designed to look at that subgroup. When we do look at that subgroup, we actually do see that there's a benefit reached, but that trial did not lead to an FDA approval or a change in established standard of care, even if there was a signal in that higher PD-L1 expressing subgroup. So 2 really disappointing initial trials. And so that led to a lot of interest in, rather than giving immunotherapy with chemoradiation after chemoradiation, giving it before in the neoadjuvant setting, before radiation or before surgery. And this actually was quite promising. There was a number of trials testing initially 1 dose and then 2 doses of pembrolizumab before surgery for surgically treated local regionally advanced head and neck cancer, again, showing very promising response rates in terms of pathologic response and in terms of survival outcomes.
So can you just mention what a pathological response is for us?
Yeah, pathologic response is at the time of surgery, when in our case, the head and neck surgeon removes the tumor and the tumor bed, they submit that specimen to the pathologist. The pathologist looks at that specimen and characterizes if they see any evidence of treatment effect within the tumor bed. In other words, is all the tumor there as you'd expect it to be in an untreated patient? That would be no pathologic response. Or is there evidence of, once the tumor is removed, of the tumor only involving some proportion, right? 70% of the tumor bed, 50% of the tumor bed, 10% of the tumor bed, and that we call treatment effect. And there's been multiple cancer types where we know with immunotherapy that the degree of treatment effect, in other words, the proportion of viable tumor within the tumor bed, is an important predictor for outcome, as we might expect biologically, right? It suggests that immunotherapy is doing something that we want it to do to the tumor. And so there's been a couple different ways of looking at pathologic response. The one that's become most established, I would say, is 2 markers. One is something called major pathologic response, which is actually one of the primary endpoints, or one of the key secondary endpoints, I should say, of the Keynote 689 trial that we'll talk about. And that's defined as less than 10% of viable tumor, right? Meaning that 90% of the tumor bed is not viable tumor, but rather treatment effect, right? That's considered a very good response.
Mm-hmm.
Of course, pathologic complete response is the cleanest marker. That means no viable tumor at all. We'll talk about the numbers, but it turns out actually both of those are uncommon in head and neck cancer. Certainly, pathologic complete responses are not very common, but many patients who have less than a major pathologic response are likely also benefiting. And there's actually been a number of analyses of different degrees of pathologic response. And it turns out that oftentimes less pathologic responses also ends up suggesting a benefit with immunotherapy in these patients. So we call it a surrogate endpoint, right? Meaning that it's an early look at a marker that likely predicts outcomes that we care about, like event-free survival, basically the likelihood of the cancer recurring or death, or hopefully it'll translate into overall survival as well.
Amazing. So let's get into the data.
So the Keynote 689 trial, this was a trial that was a phase 3 trial that randomized against surgical head and neck cancer patients, so surgically treated head and neck cancer patients, to one of two arms. The control arm was upfront surgery, followed by adjuvant, meaning after surgery, adjuvant radiation with or without chemotherapy based on the pathologic risk features, which is the way we
Normally do it.
historically have treated these tongue cancers,
Yeah.
or local regionally advanced head and neck cancers. And the experimental arm added pembrolizumab in a very interesting way, actually. 2 doses of pembrolizumab before surgery, so neoadjuvant, and after surgery for 15 cycles after, both during the chemoradiation or during the radiation or chemoradiation, and then as maintenance for an additional 12 cycles thereafter. This trial enrolled stage 3 and stage 4 local regionally advanced head and neck squamous cell carcinoma that was planned to be surgically treated, and the primary endpoint was event-free survival. The primary endpoint was positive for event-free survival. It was in the PD-L1 CPS, combined positive score 1 or greater population. The hazard ratio was 0.7 with a p-value of 0.0014. At 3 years, the event-free survival for the pembrolizumab arm was 58.2% as compared with 44.9% in the control arm. And again, highlighting the fact that this was a positive study.
Significant study.
Significant study.
Yeah.
And in terms of overall survival, not yet mature. In the high PD-L1 CPS 10 or greater population, so the highest PD-L1 expressors, it trended towards the survival benefit, hazard ratio 0.72, but again, not yet mature. So we'll have to wait and see what ends up happening with that. A couple important things to point out about this study. This was almost exclusively an HPV-unrelated head and neck cancer population. So
could you explain that? That's really important. Yeah.
Yeah, that is really important. So the trial actually allowed enrollment for very high-risk HPV-positive oropharynx cancer, but patients had to have very advanced disease, T4 or stage 3 HPV-positive oropharynx cancer. But in practice, those are not surgical patients, right? And it turned out, as expected in this trial, this was less than 5% of the patients had HPV-positive disease. So this was almost no patients with HPV-positive. This really is an HPV-unrelated head and neck cancer trial of surgically treated head and neck cancer patients. So the vast majority of these patients were oral cavity cancer, right? So tongue cancer for mouth cancer, right? These are the HPV-unrelated cancers that are treated with primary surgery, right? That's the population that this is largely incorporating. There was also some advanced larynx cancer patients, right? Patients that would go for total laryngectomy were also included, right? Not the patients that were eligible for larynx preservation with chemoradiation, but mostly an oral cavity HPV-unrelated head and neck cancer population. That's really the population that we think about this paradigm for.
Can you explain to the audience, you mentioned squamous cell carcinoma, head and neck cancer. Can you just relate to how frequent that squamous cell carcinoma is in head and neck cancer? Is it the primary tumor that's mainly found in all head and neck cancers, or how common is it?
Yeah, in the US, we see about 70,000 new cases of head and neck cancer overall. Of those, a substantial proportion now are HPV related, which is not part of this. But of the HPV unrelated, oral cavity is one of the more common primary sites where we see this. So this is a substantial population. I will point out that many HPV unrelated head and neck cancers are treated with primary chemoradiation, non-surgery, right? So oral pharynx, larynx, hypopharynx. Those patients were not included in this trial. This was really a surgical trial, patients that were treated with primary surgery.
So these patients wouldn't have the morbidities associated with radiotherapy. What's the visual of these patients?
Yeah, these are patients with, tongue cancer is probably the most common, and this is quite a difficult disease. Tongue obviously is high value real estate for us.
Yes.
Patients use their tongues for speech, for swallowing, for communication, cosmesis. So a lot of very critical functions. Oftentimes, tongue cancer starts as an ulcer or with pain that persists. Sometimes these tongue cancers can proceed as leukoplakia or dysplasia, which is sort of a precancerous condition that can lead to a tongue cancer. And the patients that enroll in this study were patients that had local regionally advanced disease, which means that their tongue cancer had to be large or deep enough or have spread the lymph nodes to qualify for local regionally advanced disease. And oftentimes these are very symptomatic patients. I will point out the fact that actually with pembrolizumab alone, as per the 689 trial, we don't think about shrinkage as the main goal here, actually. The endpoint here was event-free survival. So we give the immunotherapy before and after surgery with the aim of improving event-free survival, reducing recurrences. And, decreasing events for tongue cancer is a critically important thing. These are not benign events, right? An event, a recurrence, is a very difficult thing to treat, a very symptomatic, morbid thing to occur to a patient to have a recurrence, either in the tongue or in the neck or otherwise, or distantly. We know that survival outcomes are quite poor for patients once there's a recurrence. And so, getting immunotherapy as part of the perioperative paradigm to improve event-free survival, I think, is a meaningful endpoint. And we'll have to see what the survival looks like long term.
It's going to take a long time.
It's an important endpoint. It's an endpoint that's validated, that the FDA accepts for FDA approval and everything like that.
So let's go back to your previous episode. You talked about liquid biopsies in the neoadjuvant setting. So how does that fit into this trial or not fit into the trial?
Yeah, so we haven't seen liquid biopsy results from this trial. I would love it if we could, but of course, given what we've learned about liquid biopsy, as we talked about in the previous episode, there's a lot of opportunity to use liquid biopsy to make this treatment even better, right? We know that in head and neck cancer, there's two different kinds of liquid biopsy. There's a type of liquid biopsy called a tumor-informed. That's really the type that's most relevant for this disease, where a personalized tumor DNA blood test is generated and can be assessed in blood. And there's been a lot of data that early changes in circulating tumor DNA is a strong predictor. We've showed this, we talked about this in the previous episode, and others have showed this is a strong predictor of response and clinical benefit with neoadjuvant immunotherapy-based treatment. So there's a lot of interest in incorporating that in these types of treatment and looking at that in these types of trials. We're looking at that in our ongoing trial, which is looking at a PD-1 CTLA-4 bispecific called volrustomig in the neoadjuvant setting. That's a neoadjuvant immunotherapy trial that's ongoing. We're looking at circulating tumor DNA in that trial. There's a very interesting data from ASCO that I'll highlight.
Yes, can you talk about the ctDNA data there? Because that was quite remarkable.
Yeah, I think one of the, certainly the blood ctDNA assays are quite interesting and promising. What I was going to highlight is there was also data using the post-drainage lymphatic fluid. So after a head and neck surgery, the surgeons will, after a neck dissection, actually leave a drain to drain the lymphatic fluid after surgery. And so there's been some studies showing that finding circulating tumor DNA, not in blood, but in the lymphatic fluid, also seems to be a very interesting predictor of recurrence. And that's something that the Pittsburgh group in particular has been looking at. I thought that was a very interesting finding as well. But yes, looking at it in blood after surgery and after radiation is a strong predictor. There's a lot of interest in using that to, escalate or de-escalate therapy to improve outcomes for patients.
So we've talked about the non-HPV patients. Can you step into now your specialty, which is looking after the HPV patient and the associated data that happened and published at ASCO?
Yeah, absolutely. We presented data from our Target HPV clinical trial. This was a de-escalation trial for HPV-positive head and neck cancer patients that tried to do something new. We tested neoadjuvant HPV therapeutic vaccination. or HPV therapeutic, HPV-specific immunotherapy. So this is a drug called HB200 given intravenously, which is a drug that is a viral vector that has the HPV proteins inside of it, E6 and E7, non-oncogenic. So these are not proteins that can cause cancer, but they look like, for lack of a better term, the actual HPV viral proteins. And this is given IV, and so this is a drug that activates the immune system, the T cells in the body, to be specific and expanded towards HPV cancer cells. It's a very promising strategy. There's been a number of HPV-specific immunotherapies that have looked quite promising. This particular one, particularly in combination with pembrolizumab, looked quite promising, and particularly the higher PD-L1 expressors, which led to our testing it in the neoadjuvant setting. And we found, first of all, that this was safe and tolerable. I will point out that, this, as with many of the HPV immune therapies, there are some viral toxicities that we see: fever, chills, joint aches, kind of like a viral illness that we observed in most of the patients. But none of that was, we didn't have any grade 4 or grade 5 toxicities related to the vaccine. And we actually found interesting preliminary efficacy signal also. So deeper responses than we would have expected with chemotherapy alone based on our historical data. We actually saw that the majority of patients expanded their T cells, so their T cells, which were not specific to HPV prior to treatment, after treatment, was expanded in the blood. Again,
So can you explain
yeah.
what a T cell does
Oh, yeah,
and
sure.
because I mean, we're
The T
talking.
Yeah, the T cells are the immune cells that are responsible for killing cancer cells.
Mm.
And so with HPV cancer, one of the nice things about it is that it can potentially visible to the immune system, to the T cells. That means that in the same way that a T cell might target a virus or some other microbiome in the body that causes disease, right? We hope to leverage it and harness its power to kill cancer cells. That's the idea behind using this drug.
Amazing science. It's amazing science. How many patients were involved in your study at this stage? I mean, this is preliminary. It's not approved yet, but it gives an idea to our listeners what the research is heading and how many patients.
Yeah, it was a phase 1, phase 2 trial. It was 35 patients, 35 evaluable patients. So,
Good
enough
number.
to generate a signal, but
Yeah.
certainly not definitive.
Yeah.
It does support further development of this HPV therapeutic vaccine and other HPV therapeutic vaccines in the neoadjuvant setting in HPV-positive head and neck cancer, in my view.
So how does this relate now? Because now you're going into the neoadjuvant setting and adjuvant. These trials are going to take years because following that is your advanced stage. So the survival events or event-free survival events are going to go out for many years. So if we're waiting for event-free survival as the endpoint,
We have to do the studies.
but your
Oh,
time, it's
it
time.
does take time. It does take time, but we know that randomized trials are the validated way, as you know this, John,
Yes, I
obviously.
know.
And it takes investment, it takes partnership, it takes collaboration with patients, caregivers, advocacy groups. We greatly value those stakeholders at our center, and it's really important that we continue to do these studies because we need to bring these exciting new drugs to patients.
It's a great
And
message
look,
to our listeners.
we saw data from ASCO with amivantamab, again, the EGFR MET bispecific antibody, in heavily pretreated immunotherapy, platinum refractory head and neck cancer patients, very high risk, very poor prognostic patients. Response rate, 42%, central review, 47% investigator review, complete response rate, 15% in this highly refractory head and
Wow.
neck cancer population, and overall survival for that cohort about a year. Remember I said
Yeah, 6
about 6
months.
months based
Yeah.
on the real world data. And so, things are moving, things are happening. We just need to continue to study the patients, to do the trials, and do good science to try to advance treatments for head and neck cancer patients.
So on the biomarkers, we were talking earlier about ctDNA and the role of ctDNA. There was a lot of discussion regarding at ASCO with ctDNA. There was so many publications, posters on it. How do you see ctDNA moving in your field, in head and neck cancer, salivary cancers? Is it the be all and end all, or is it has its place in the role of diagnostics?
There's been a lot of promising data showing that these assays have become quite sensitive and specific for head and neck cancer. And in fact, the detection at any point of ctDNA or minimal residual disease, MRD, after treatment is strongly predictive of recurrent disease, unfortunately.
So you're a hematologist oncologist. So MRD, minimal residual disease, is a big thing in heme, right? It's moved into solid tumors now. So can you explain what that is and how it's related between the two cancers? Because you get that discussion in both areas now, which is new.
It's very similar, right? Which is that tumor cells shed small amounts of DNA into the bloodstream. And these can be detected and quantified based on a simple blood test. A liquid biopsy is a bit more advanced, and you might expect that. Hematologic malignancies, I meant to say, are more advanced in that regard. Sorry about that.
It's life,
for neighbor warning here in the Chicago area, so I can't suppress that one. But so hematologic malignancies obviously is a blood cancer, so it makes sense that that's where many of this MRD started. But you're correct. Even small tumors can leak out, for lack of a better term, minimal residual disease or tumor DNA into the blood, which can be detected and quantified. And it turns out detection of this can proceed, in some case, many months or years prior to the development of recurrent disease. And I will say, I'll put in a little bit of a plug, that we actually have a trial open at our center now where we're actually testing immunotherapy in patients who are MRD positive after treatment, meaning that they have a very high risk, almost 100% risk of recurrence, but haven't yet developed any evidence of disease on scans or physical exam.
Can you explain the trial and the protocol for that?
Yeah, the trial is enrolling patients who have an MRD positive test, meaning a blood test positive for microscopic head and neck cancer in their blood at any point after completing treatment, right? These are patients that are, after completing treatment, many oncologists are doing tumor DNA surveillance, right? Blood tests every 6 to 12 weeks to identify this population. If patients are MRD positive at any point, then they can enroll in the study as long as there's no imaging evidence of definitive disease requiring treatment at that time. And they're randomized to one of two arms. One arm is cemiplimab, which is a PD-1 inhibitor alone, or cemiplimab in combination with fianlimab, a LAG-3, another immunotherapy combination. And the primary endpoint is recurrence-free survival. So we're looking to see if the cemiplimab-fianlimab combination improves recurrence-free survival in this population, this high-risk adjuvant population, over cemiplimab alone. So if any oncologist or any patients are told by their oncologist, or if an oncologist does a blood test that's positive for MRD, that's a very challenging situation for patients, obviously, because you know that a recurrence is coming, but you don't know when, you don't know how, you don't know how to detect it. Very difficult situation, obviously very anxiety-provoking for patients, for oncologists. Now there's a trial that we can enroll to, where we give immunotherapy alone or in combination to try to improve outcomes, and that's something that we're offering to our patients. So any patients that have that situation that might be interested in the study.
So would they be reaching out to you directly, Ari, or to Chicago Medical Center? How would they get in touch? I can put a link in the highlights of this video so patients can find you, or how?
Yeah, that'd be great.
Is
I'll I'll
Yeah.
send you a link that you can put in the show notes or however
Yes,
you.
in the show notes. Yeah,
Great.
yeah, yeah.
That sounds great, and feel free to reach out to us, and we'll get you in and evaluated quickly so we can help with your treatment plan. We just want to be supportive of patients and help patients do better.
And this is US, right? Doesn't make any difference where you are, because obviously this episode goes globally, as I mentioned before, where we're in we're in the Southeast Asia area, we're in Japan, we're in Europe and across the
Yeah,
world. So
but even then, feel free to reach out. We do international consults all the time, and we have a number of international patients. But you're correct. We're based in Chicago, Illinois, home of the annual ASCO convention.
I know 45,000 doctors attended this year. It's amazing. Amazing.
Amazing,
It's
amazing.
amazing. So just in a wrap up, we did touch on advanced cancer. You did talk about latest breakthroughs there. Is there anything you want to add to your earlier statement regarding new treatments coming out for advanced cancer and head and neck?
No, just that I think the takeaway is that there's a lot of promising new drugs being tested in trials in the advanced head and neck cancer setting. We call that the recurrent metastatic head and neck cancer setting. And beyond, we talked about the EGFR bispecifics that are in frontline and later line phase 3 trials. And I touched on some of the drugs that have been promising, in particular amivantamab and petosemtamab, I would say. Antibody-drug conjugates have been quite promising.
Yes.
A number of different targets. We've been very interested in Nectin-4 as a target, which is a validated antibody-drug conjugate, which is a validated target for urothelial cancer, right, bladder cancer, where enfortumab vedotin is an approved therapy. And so enfortumab vedotin had promising activity in head and neck cancer. There's now a next generation Nectin-4 targeted ADC called CRB-701 that is now moving from phase 2 into a phase 3 trial. That's quite exciting, along with a number of antibody-drug conjugates, and then multi-targeted kinase inhibitors. So we have a trial of zanzalintinib, along with a PD-1 inhibitor, pembrolizumab, and cetuximab, an EGFR inhibitor that has multiple targets. And so we're testing that and recurrent metastatic head and neck cancer as well. So a lot of exciting things happening, and it's about finding the right treatment and the right trial for the right patient.
It sounds very exciting at Chicago Medical Center. So congrats on that. It's an amazing medical center, and obviously now the listeners can hear just the plethora of research that's happening there. So congratulations. Ari, my usual sort of thing is you had to summarize this episode and you wanted to give 3 points to the listeners as we wrap up. What are your 3 points?
I think the 3 points are, number one, that head and neck cancer continues to be a very difficult disease to treat. We know that outcomes, particularly in the recurrent metastatic setting, are poor. There's a need for improved treatments. And there's also a need to cure more patients in the local regionally advanced setting. That's one. It's more than one, but I'll call that one. I think two is that we've seen the beginnings of real innovation and practice-changing research within the past year, with the standard of care changing, where now immunotherapy is a new standard of care for surgical patients. And three, a lot of new drugs that are very promising in the advanced patient setting that we'll have to see what those trials read out as, but certainly a lot of promise for improved outcomes for head and neck cancer patients across each of these disease settings, which is what we want, what patients want, what patients care about, what family members care about. It's a horrible disease. We need to continue to do better.
You're amazing. And congrats. And I just want to thank you for this episode. And I implore all our listeners to go to, as I said, the 3 previous episodes regarding head and neck cancer. Everything from diagnosis to the potential for cure is Ari's covered off in the episodes. And an amazing person. Congratulations to your team and the work that you're doing. And on behalf of MedInsights Unleashed, thank you very, very much, Ari, for everything.
Thanks so much, John, and congratulations to you as well on all the success.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.